you some details about. um, yeah, I'll go through what it's like to be an anaesthetics doctor and give my little 2 cents on why it's the best career to go for in medicine. Um, so a little bit about me. I studied medical school down in the southwest in Peninsula Medical School. Wouldn't entirely recommend, but alhamdulillah, obviously did foundation training, and I've done a clinical teaching fellow for an F3. I'm actually currently on maternity leave, so please bear with me if I am. It looks like I'm reading off the slides because I am, and my mum brain is just not the one. But otherwise, before I went on mat leave, I was in my CT4 year of ACCS anaesthetics, and I was working. I'm currently in the Warwickshire Deanery at the University Hospital, Coventry, Warwickshire. And yeah, I'm an anaesthetic doctor in my 4th year of core training. I went into anaesthetics sort of blindly, but I knew that I wanted to do a career where you do lots of practical procedures. You're very in touch with patient care. You're not stuck in an office somewhere looking at screens. But I really enjoy being involved in acute presentations and a constantly dynamic environment. I'm not someone that can sit down in a GP practice, for example. So that's why I applied to anaesthetics, and that's where I am now. So what is ACCS? So some of you probably already aware that it stands for the Acute Care Common STEM Training Pathway. So what it is that you are doing a common STEM of training as other acute specialties, which the acute specialties are anaesthetics, emergency medicine, and internal medicine. I think internal medicine used to be called acute medicine, and they've since changed it because acute medicine wasn't really working. And essentially, you do the first 2 years of training the same. So as you can see from the slide, all of you together are kind of lumped together. Do 6 months of emergency medicine, 6 months of acute med in your first year, and then 6 months of anaesthetics and 6 months of ITU. And you're all meant to kind of end up with the same sort of skills and transferable skills after the first 2 years. And then you go on to complete whatever your parent specialty is. So for anaesthetics, for example, you do just pure anaesthetics from the year 3 and year 4 onwards. You start doing obstetric modules and pain modules and things like that. But those first 2 years are core competencies. After those 2 years, even though you're all ACCS training doctors, you don't really see each other after that. And emergency medicine, just to touch on emergency medicine, if anyone's interested in that, ACCS emergency medicine is the only only sort of entry level post foundation training. Like if you haven't like done training abroad, you have to apply to the ACCS emergency medicine. That's the only entry. It will be the only thing that you apply for on Oriel. You all have to do ACS basically if you want to do emergency medicine, but it is run through, so you'll go through your full 6 years of training after you've done the initial bit. And then with internal medicine, you'll complete a 3rd year, and then you'll apply to whatever higher ST4 internal medicine, general medicine specialty that you go on to do. So if you're interested in that, those are the different sort of specialties that you can apply for within ACCS, but you're ultimately choosing a parent specialty, and you will do the same sign-offs for those first 2 years, but you have applied to emergency medicine. And although it seems like you might be able to kind of like switch in between, it's actually quite difficult to switch. So if you have gone in to emergency medicine, for example, and you did a bit of anesthetics and you thought, actually, I really want to be an anaesthetist, you can theoretically apply to then switch over, but they can be quite challenging about it and quite difficult about it. And actually, I know a couple of trainees, one or two trainees, that have been, they make you like a repeat some of your training, which is really unusual, but it might be different in different deaneries. This is what I've seen in Warwickshire. So while it looks like you can kind of swap in and swap out, you start with, you have applied to Oriel through you choose your parent specialty, and then you do the ACCS bit, and you have the same sort of sign-offs. That's the other thing to mention. So you're all doing the same sort of like portfolio sign-offs. There's a bunch of procedures that you all do. It's all the same for all of you for those first 2 years. With I'll go into sort of how in anesthetics, there's obviously two entry points. So it's either core anesthetics or ACCS. I'll explain a bit more, but essentially, the procedures and things that you have to do as part of ACCS, you won't necessarily see that your core anesthetics colleagues have done the same. So, for example, your internal medicine or acute medicine rotation, you'll be sort of expected to do acidic taps, pleural taps, chest drains, and all of these things that some of your core anesthetic colleagues wouldn't have done. So that's possibly an advantage for choosing ACCS anesthetics over core. So yeah, here's my brief summary of the difference between ACCS and core anesthetics. So ACCS anesthetics, as you saw on the previous table, is 4 years, whereas core anesthetics is 3 years, and that is because of that first year where you are doing a year of acute med, a year of acute med and emergency medicine, and the whole anesthetics and ITU bit is a bit, once you, speaking as someone who's gone through it, after you do your first year of acute medicine and what's it called, emergency medicine, you then start your anesthetics and your ITU modules. You're essentially seen as a CT1 in core anesthetics, so you just end up doing the same sort of things in the anesthetics module. The only thing is that obviously you don't do an ITU module in the core anesthetics. So as I mentioned, you'll have additional experience of managing acute presentations in the ACCS pathway, and you have an ITU component, which if you are interested in ITU, you can actually do ITU and become an intensivist without doing anesthetics. But you can also do it with anesthetics. So now, if you want to become an intensivist, you have to apply to do dual training. So you at ST4 you apply to intensive care medicine and anesthetics, and that means that, for example, general medics can also enter ITU through that pathway as well. So they will do dual training as well. And part of that ITU, if you want to become an intensivist, you have to do a placement in acute medicine. So because you've already done 6 months of acute medicine in ACCS, you don't have to do it in the later when you want to become an intensive care anaesthetist or whatever it may be. I hope that made sense. So obviously, negative negative point is that it's longer training, and it's shorter for core anaesthetics. Um, but you will ultimately have less experience, unless you've done like an F3 in emergency medicine or F3 in acute medicine, or whatever, and you've got lots of that like experience with acute presentations, like exacerbations of COPD, asthma, lung collapse, etc., etc. You're gonna probably not be as confident. And I mean, I haven't. I've got one colleague that's a core anaesthetic trainee, and they can see that there's not actually that many core. I don't think there's any core trainees, core anaesthetics trainees in the deanery. And I'll just explain in a bit, but uh, essentially, um, that's a big part of your job, and you'll it's advantageous to obviously have that experience. However, um, when you if you want to decide between ACCS and core anaesthetics, there is a large geographical component, which I wasn't aware of until I was applying. And I personally did not want to do acute medicine ever again, but it just happened that it's changed now. Actually, once I updated my slides, there used to be a lot more ACCS jobs. Actually, now they've balanced out. They've made a lot more core jobs, but you'll still find that in certain deaneries, for example, Warwickshire, like I said, does not have core anaesthetic trainees. So if you wanted to stay in Warwickshire, you would have to do ACCS. Um, it's a service provision thing, unfortunately. I and it feels like a service provision thing, if I'm completely honest. But I do see the benefits of it now that I'm this far into my training. Um, so yeah, both trainees will leave with the same competencies in sort of core anaesthetic level, but you'll have just different levels of confidence with certain things, and both pathways. Um, you're required to pass the whole primary FRCA before you apply to ST4. Things are getting more competitive, but it's not the most competitive. So in 2023, there were 2,604 applicants for 545 places. That's in England and Wales. So the competition ratio is 4.7. It was half of that when I applied. I think it's just because it's a sick specialty. But they have actually increased the number of places as well. So don't let it put you off, but I just thought I'd work that number in there. So yeah, just to be mindful. So this is to highlight the number of places in each deanery. So as you can see, like if you wanted to go to the East Midlands, there's more chance you'll get a core anaesthetic trainee post. So have an open mind, I would say, because the competition is getting harder. So if you have any particular preference, either way, you know, there's clearly a geographical element here. I'm not sure why. Actually, I know why. It's service provision. But yeah, as you can see in the West Midlands, Warwickshire comes under where I am, comes under West Midlands. There's way more ACCS posts, and honestly, I've not come across a core anaesthetic trainee. So it's a zero. It was zero. So yeah, just be aware of that. So I've gone into I've dived in a little bit into that whole ACCS shenanigans, but for those of you who are just like, oh, I just want to know what the hell an anaesthetist does. So I didn't actually have a great deal of knowledge about what an anaesthetist does. People just kind of recommended that I go for it, and now I'm like, yeah, I can clearly see why. You are equipped with a range of skills, or you are trained to become equipped with a range of skills, and it's things like airway management, intubation, ventilation, managing acute emergencies. So there's a lot of acute emergencies that could potentially happen. You have your anaphylaxis for like drug reactions, because obviously you're giving lots of exciting drugs to these patients to put them asleep. You required a lot of manual dexterity, especially with all the lines that you'll have to put. Nerve blocks require a lot of manual dexterity and ultrasound skills. And ultrasound skills are really, really useful to have. And it's, I mean, I'm not saying I'm good at it, but I felt so empowered once I had ultrasound skills, because I'm sure some of you have been like, damn it, if only I knew how to do venipuncture under ultrasound guidance. And you get trained in it, and it's awesome. And you do nerve blocks with ultrasound. You have like a very in-depth physiology and pharmacology and physics, understanding of physics, because it's it's part of your day-to-day, especially physiology and pharmacology. That's the mainstay of your understanding of sciences. And obviously you have to be a bit of a people person, and you have to be able to communicate, because you're working part of a team. You have ODPs, you have surgeons, you have scrub nurses, you have all kinds of people. You have to really be patient centered, and you are the person who is like the mesh between everyone. And obviously, because it's it can be life or death. If you have a really sick patient who's coming in for a laparotomy, you have to be able to work under pressure. Any major bleeding, you need to be able to be decisive, put the double two call out, and lead a team essentially. And you'll work in a variety of places. So you'll do theatres, is like the bread and butter of what an anaesthetist does, and that's obviously general trauma, cardiac, and obstetric theatre. So there's a lot of obstetrics in anaesthetics, and you'll make sure you'll be dealing with the perioperative care side of things. So that's optimization of the patient before doing the pre-assessment, etc., and then making sure they're safe throughout the surgery, and then post-op analgesia and fluid monitoring. Then obviously you have the ITU component. So there used to be this whole like, oh, there's going to be a big divide between anesthetics and ITU. You will still find the majority of anaesthetists in the UK have intensive care training, and a lot of the intensivists are still anaesthetists by background. So yeah, you'll be dealing with sort of critical care and organ support, renal support, etc. And there's obviously a large component of pain management involved in an anaesthetist job. So both inpatient and outpatient. So you could be doing clinics or acute pain rounds, and regional anesthesia or analgesia is becoming a much bigger thing. So I don't know if I didn't know much about it before I started, but nerve blocks for surgery, we're trying to move away from opiate heavy analgesia, because a lot of patients don't tolerate it well, and it's got lots of side effects. So nerve blocks are becoming a lot bigger, a lot more prominent, of a key skill. And labor analgesia, so that labor ward, once you get to my level, you basically feel like you're living in the labor ward, because you're always there, mostly for on calls. But yeah, it's such a key component. Epidurals. It's like coming out your ears. So what is a typical day for me? There is no real typical day, but actually I tell you, it is pretty typical. People say it's repetitive and boring. Do not listen to them. It's wonderful life. It's a wonderful life. So you would start off a normal day, sort of in the morning. Unfortunately, it's very early starts, and that's probably the biggest thing that I struggle with, is those early starts. You're like amongst the first people that are in the hospital after the nurses that start at 7. You do your pre-op assessments, you make sure the patient's ready for theatre, optimize anything that needs optimizing, give pre-medication, PPIs, prevent them from having any issues with their airway. You go do your theatre list, whether it's general inguinal hernia list, and you'll be potentially guided by your consultant for different training opportunities. So if there's something interesting in the theatre next door, you might go and do the intubation for that and see anything interesting. And it's very kind of fluid, but usually you're expected to do the bulk of the case. You'll be the one intubating, you'll be the one cannulating, you'll be the one giving all the blood pressure support medication. You'll be encouraged to do everything as much as possible, and you're always supervised. When you're on call, you will be doing all of the above, plus you'll be going to emergency theatres. You can be doing that. It depends on what modules you need signing off, but usually you're in the emergency theatre all day up until handover, and or labor ward or labor obstetric theatres. But sometimes during the daytime you can be elsewhere, and then you have to go into the emergency theatres after 5 to pick up the bleep and stay there. But yeah, you're also liaising with specialties. If someone's had an RTC and they need like general surgeons and orthopedic surgeons, sometimes you have to be the one that's like, okay, can we call the general surgeons now? Because or you might be speaking to them directly and be like, listen, the general surgeons are done, can the orthopedics now fix the bones? And there's just lots of communication that you might be the person's trying to liaise everything. And this isn't the case in all hospitals, but sometimes you'll be part of the cardiac arrest team, which is always exciting, but you're always basically managing the airway at my level, if it needs managing. So yeah, that's a typical sort of day in a life. A big thing, and not a fun thing, but a big thing about anaesthetics is the exams, and we have to talk about it because I feel like I kind of went in a little bit blind, but it wouldn't have put me off, but it might have just, helped me come to mentally prepare myself for it. There's 5 exams in the whole of anaesthetics training, which is, I believe, 8 years long. So you go up to ST7, or if you're like me, it is 8 years because you do an extra year at the beginning. So there's the primary is the first set that you do at my level, which is core level. There's 3 exams. The first one is the primary MCQ. If you pass it, you can then sit the OSCE and the structured oral exam, it's also known as the Viva. So they're very difficult, let me just tell you. They are heavy. It's 4 domains: pharmacology, physiology, physics, and critical incidents. So all of these sort of acute presentations, they want you to be hot on managing them. So sucks apnea, as I said, anaphylaxis, laryngospasm. They obviously want you to be able to manage these things. So there's lots of exams, but I believe at some point in the future they're going to get rid of the structured oral exam Viva, because it's just really intimidating. You're literally sat in front of like 2 or 3 examiners, and they'll ask you, what is lactate, and you have to just like rattle it like you've known it since you were born, like what is lactate, what it does, and you just have to be really confident. And it's just a bit of a performance, and I think lots of people struggle with it because it's very subjective. But yeah, after that, between ST4 and ST5, you are expected to sit the FRCA written, which is MCQ, and also there's another Viva for that. So 5 exams at the moment, possibly 4, but very stressful. There's also Royal College fees, just as an aside. There's fees for everything, but yeah, it's just worth noting that. Someone has previously asked me, is there much benefit of sitting the exam before the program? Absolutely not. Nothing is going to make any sense to you, so don't waste your time. But it's worth knowing that it takes a good go of like 4 to 6 months worth of studying, and it is the most miserable time. But the job is awesome, so there's always going to be negative things with every specialty. Every specialty has its positive and its negatives. For me, anesthetics is just got a massive negative exams. Anyway, moving on. So how do you apply to anesthetics, which I hope you all will? My take home message from this slide is look at the Anaesthetics National Recruitment website. And look at the person specification for CT1. It will go through, there's a big document, it will go through all of the qualifications. It's just basic, like undergraduate, you've got a BMBS or whatever. It'll go through the different eligibility, fitness practice, etc., etc. And you can just see if ACCS anesthetics or core anesthetics is appropriate for you. One thing that it only made sense to me afterwards. It was like, oh, of course, like, why would you need 6 years of anesthetics why would you apply to core anesthetics with 6 years of experience? You have to have under 18 months of experience in anesthetics. So you basically have to be a newbie. Otherwise, it's pointless for you. Like, it's going to be pointless. There's 2 recruitment intakes. I believe it's August starting and February starting. You need to check the timelines on when to actually apply for those different intakes. And I'm not 100% sure. I was trying to find the details of this, but the recruitment intakes, I think there's more places when you apply for the August intake, but don't quote me on that. Do your own research for that one, okay? So yeah, there's lots of spots to go through. And the MSRA is another thing. So obviously you have to sit that. I was lucky enough to dodge that one, so I cannot comment on what it is you need to do to pass or get a good score, etc. Hopefully you can find out from one of the other lovely speakers on this series. But yeah, it's a big one, but it doesn't account for a huge amount, as I'm sure you're aware. So I'll go into it in a bit. So there is a self-assessment criteria for the portfolio. So you'll have an interview and you'll have a portfolio sort of scrutiny as part of your interview. I had to do this was pre-COVID, so, or into COVID. Actually, no, I applied pre-COVID. So there was in-person interviews, and then I jumped into COVID for my CT1 year. So we had to do like a lever arch binder style. And I think it's always useful to have a lever arch binder style portfolio if you haven't already, which includes all of your undergraduate degrees and prizes, postgrad qualifications, medical experience, committed, all of this stuff that I've listed here. I'm sure you can read it. And they go through it, or they scrutinize it in the interview, I believe, or pre-interview. And I'm probably not the best person to ask because I feel like I've time warped. So if you can find someone who has recently applied post-COVID, applied to ACCS anesthetics, then double check with them whether you still need to like upload all of this evidence. But regardless, I'm sure there'll be a point where they see limitations in the online interviews and go back to in real life interviews, and you'll have to have physical evidence for everything. So obviously, I'm sure you guys all have your actual degrees, but if you have evidence of your publications, print them out. Any audit presentations you have, print them out. If there isn't, I was always taught that if there isn't evidence for it, it didn't happen. So even if there's pictures of you presenting something, that will count. The thing for the self-assessment is that there's different points for like the degree, the extent to which you fulfill the criteria. So for example, with research, you will get like maybe 1 point if you have participated in data collection. However, if you have taken that research to a peer-reviewed journal, you'll get both points, like max points for the fact that you've done all of this research, or you've done like maybe an MD, or you've got a qualification in your research, you'll get points for the research, and you'll get points if you've like presented that research at an international conference. So there's like, the more in depth and the more you've done a particular domain, the more points you'll score on the self-assessment. So for example, for me, teaching, I actually applied to anaesthetics twice. First time I was in my F2. I didn't have any teaching experience, but I knew that I was applying to this clinical teaching fellow. So when I was in my F3, I applied to anaesthetics. My clinical teaching fellow, by the way, I had they were paying for a PG cert in medical education, so I knew I was going to get that qualification. But only unless you have that qualification do you get the points for it. So when I had written it on my self-assessment, they actually deducted points for me because I had said that I was doing the degree, but I didn't have the certificate, because obviously I could have just like tapped out at any time. But what I did get points for was I acquired a letter from my supervisor saying that I had made a significant contribution. So you want to look at the wording of the criteria for this, the self-assessment criteria. It's very specific, and I basically wrote out this letter. I showed it to my supervisor. I was like, are you happy to say that I made a significant contribution? I was teaching final year medical students, and it was a national curriculum essentially. So I made significant contribution to the national curriculum, and I got like the points below the PG cert qualification for teaching. Does that make sense? So just have a good look at the self-assessment criteria. Other things, if you feel like you are not a super academic person with loads of papers and loads of whatever, I was honestly really not. But I had loads of activities and things that I did outside of medicine. I was really into like my society stuff at university, so I had loads of evidence for that, and I got like the maximum points for activities outside of medicine and leadership. So don't ignore your extracurricular activities either. So we'll leave that at that before I exhaust this slide. But the take-home message is: look at the self-assessment criteria in depth, collect evidence now. So yes, the interview. So as I said earlier, the interviews are now online, and it counts for 85% of your final score, as it were. The other 15% is the MSRA exam. And you have 2 stations in the online interviews, so 15 minutes each, and you can only score a maximum of 30 marks. Again, I did the IRL interviews, which in my opinion were way more intense, but we had to do like a whole presentation thing. That's not necessary. They're just going to do a clinical scenario for you and expect you to talk through it confidently, succinctly, and then they'll do a general station where they will ask you things in your portfolio. Talk us through a quality improvement project that you did, or talk us through a positive impact you've had in the hospital, or talk us through one of your proudest achievements to date. Or they might, and they're starting to introduce this now, ask questions about the NHS. Talk us through one of your something you would want to improve for the NHS, and they just want to see that you are well spoken. You have a good understanding of what it not necessarily what it takes to be an anaesthetist, but what it takes to be a good doctor. Like, you've got good bones to you, and you're friendly. Like, it's honestly the basic things, but they want to see that you're like a reflective person, and you're not just kind of like waltzing through your foundation training and hoping to become an anaesthetist just for for BANTS. They are, looking for a future consultant, So you'll get 30 marks max each. And then there's something called a global rating, where you have 10, there'll be two assessors in each station. So two assessors in the clinical station and two assessors in the general station. And each of them will give you a global rating, like a general impression of you out of 10. And so 60%, 60 marks out of 100 can be obtained from the clinical station and general station. 40 marks out of 100 will come from your global rating. So it's really important that you have like good communication skills, open, honest, smiley, etc., friendly. They just like your vibe. And to be appointable for a post, you have to score a minimum of 60 out of 100 marks. So obviously, as you saw, there's like thousands of people that apply. There's only 500 and can't remember 45 posts. I've got it on another side. Anyway, thereabouts. There's a lot of people that are going to be disappointed. But just because you didn't get the first sort of offering of those 500 posts, it doesn't mean you won't get it, unless you've scored less than 60 out of 100. Because that was me. I think I ranked out of all of, when I applied, I ranked like 600 out of all of the, they give you a ranking after your interview, and I was really disappointed. I was like, oh, my dream's gone. But there's people that apply to multiple specialties. There's people that decide that they don't want to do anesthetics anymore, and they'll reject the offer, and then they'll offer it to the next lot of people. So yeah, so I've already mentioned that once you've done your interview, you get shortlisted, and they'll offer you the you'll have the opportunity to rank all the positions, and then you'll get the offers first. I wrote this in the wrong order, but you'll then get the opportunity to rank the positions. Once it's been accepted, you'll get communication from the deanery. I've already mentioned this in red here. So lastly, what's the time? How are we doing for time? Okay, I've got 1 minute to convince you all to become an anaesthetist. I just want to drive home the point that anesthetics is an excellent specialty. If I didn't already mention, it's a specialty that was really dynamic, really interesting. People, for whatever reason, would always say, oh, it's really boring. Yeah, you are sat down for a lot of it. But I would choose that over the chaotic wards any day, any day. Not a big fan of clinics either. Well, unless I'm doing them. But I just think that anesthetics is such a fun, and you're with a team, you're always, having banter with your ODP. You get to rest. You get toilet breaks, you get coffee breaks. Oh my goodness. It's compared to ward life, it is a different world. And there is no other specialty where you have one patient at a time. It doesn't happen. As I mentioned earlier, you're never alone. You're always supervised. Even if they're not directly in the anesthetic room or theatre with you, there's always someone who you can call on, and they're always checking up on you. I like the fact that there's a very strong camaraderie amongst anaesthetists, and even if your consultant is I don't know, they've gone for a meeting, they'll give you the number, or they'll give the bleep of another anaesthetist that you can call and be like, oh, so and so in theatre 4 is aware that you're on your own, so just call them. So you're never alone. You have your personal assistant. Well, I like to call them personal assistant, but they're the ODP. They are literally there with you, passing you whatever airway equipment you need. They're excellent in emergencies. They're very dependable sidekicks. And yeah, as I mentioned, no ward rounds. I personally like the fact that I'm on my feet a lot. Like while you are sitting down a lot, you do get up and find that you are standing about, either in the anesthetics room, like sorting drugs out, getting more drugs. It's you're not as you do get the time to sit, but you also are stood up for a lot of it, intubating and whatever else you might be doing. There's instantaneous results. You see physiology in action. You give a drug, you see the effect. It is extremely satisfying. Teamwork. You, like I said, you're part of the theatre team, and people will always want to help each other, unless you're not in their good books. But just don't be an asshole. I personally have a lot of job satisfaction because you are caring directly for a person. They are looking to you for support and for reassurance, and they feel like their life is in your hands. So you have to take that seriously, and for that reason, I genuinely feel like my patients are so thankful once they've woken up from anesthetic, and it's unmatched. Like, it's unmatched. Early autonomy. So what I mean by that is that you, as a anaesthetist, even from your first year in anesthetics, they train you up so that you are able to do on calls, and they leave you to it. They just let you do it. And when you're sat with your anaesthetist, you've done everything yourself, and your surgical colleagues in their ST7 year are still holding the retractor and just like shaking, their legs are shaking for holding the retractor for 4 hours straight and not even had a break. You just think, I've made the right choice in life. Work-life balance is great. I think things are generally getting better across the board, but as I mentioned, there is this camaraderie, and people look after each other in anesthetics because you have to be constantly of sound mind. You are making life altering decisions. Like an instantaneous mistake can be devastating if you don't call for help in an emergency, for example, and you're just tunnel visioned. They look after each other. That's why the breaks are so important. And it's just great. And you work with all kinds of patients. There's a variety of specialties, variety of patient backgrounds, kids, adults, men, women, whatever. You get it all. And just circling back to the point of a work-life balance, you leave the hospital and you leave the hospital, like, you do not take it home with you. And that for me is one of the biggest blessings of being an anaesthetist. So in summary, choose anesthetics. And anesthetics is unfortunately a very non-diverse specialty, and I really see the fruits of me being, as a person of color, someone's anaesthetist, because for that person of color, they just have that little bit. When your patient's a person of color, they have that little bit extra, like, piece of that, they're at peace a little bit better. And especially in obstetrics, when they have a female coming to do their epidural or coming to do their whatever, they just feel that a little bit more comfortable. So come through with your applications. I will see you all, inshallah. Any questions? Please feel free to email me as well. So I'll just pop my email there. If you have any questions about anesthetics or anything in life, I'm happy to answer.
MashaAllah, mashallah. That was amazing. I really enjoyed your talk. Thank you so much. And I saw the shade that you were throwing at radiology at the beginning, Sarah.
No comment.
No
No
comment. Me and
comment.
Sarah both started when we were both working in acute medicine together. So we started from the
Back in the
trenches.
day.
Yeah,
In the
back in the day.
trenches. That was the
Big
trenches.
time. We were
Oh,
really truly suffering. But alhamdulillah, we're now
alhamdulillah.
suffering with exams instead that are
Whew,
beating us up.
hitting us.
So we've got a good
Suffocating.
few number of questions. Big
Oh
time.
God. Okay.
So first question I've got for you is that a lot of people have talked about this, an ST4 bottleneck. How
Hmm.
bad is it really?
So I have also heard of this, and I'm just still trying to like get through core training. Um, so I haven't looked myself at the bottleneck, but it has not put me off. And I think it's a symptom of um like when you come to ST4, basically, I think there's other trainees from abroad that have done already a little bit of anesthetics that can't apply to core that have then come in, and you're competing with like way more people, but it doesn't mean that you won't get a spot. I've seen people who they it's just about finessing the person's specifications. They just go and target everything that they think they can, achieve. Can they get a first author on a peer-reviewed journal and max out the publication points? They do it. If they can find a way of, evidencing like the maximum points of leadership, they do it. So um, it's it's about finessing, but I have also seen people that apply like 3 times, and then they're like, I really need to just carry on with my training. And they've it's if you look at it though, they are not hitting the points for the on the person's specification adequately. Excellent anaesthetist, but it's a bit of a game. It is a bit of a game. And
Really,
in the interim, you can just do a staff grade post. It's not the end of the world. Like if you've bought a house in a deanery and you need to like stay in that deanery, you can just keep working on your portfolio while you're doing a staff grade job. There's plenty of those. So
okay,
yeah.
amazing. Another question for the dreaded exams. So, is there any tips that you have to start ahead in preparing for the FRCA?
So um there are a few things that I would say. So, um, there are books, right? Now, I personally I find it easier to read things off paper. So you can purchase the paper books, but they're all available in PDF. So make sure there is like a certain list of books that you need for the primary, and they literally the Royal College for whatever reason love these books and take the questions. They use the text verbatim and turn it into a question, and you're like, I've read this in that particular textbook. So there's specific books that you get. um know your style of study. um, I personally have to go through all of the information and deeply understand it before I then do the multiple choice questions. Um, because first of all, they've changed the exam slightly. So they used to be like multiple true false questions on them MCQ, and now they've changed them into a single best answer. So like pick one of five, and there are not that many practice questions from the Royal College out there. The Royal College are not that helpful, if I'm completely honest. There's a Royal College book that is worth getting, a Royal College FRCA. There's one for the primary and one for the final. That's useful. If you email me, I can provide you with a list. Um,
Amazing.
but yeah, there's a couple of books, and I think it's On Examination is the closest question bank to the style of the FRCA. So you will have to get a question bank for the primary, and then the Viva and OSCE is a whole other kettle of fish. So feel free to email me about that.
Amazing. So I'm going to ask you four more questions. So,
Yeah.
okay, one question is, in terms of for your core training years, do you recommend DGH or a tertiary center?
So the deanery will place you will mean that you have to go to both. So I actually did my first 2 years of anesthetic. So I did my CT 1 year in the hospital I'm at now, which is a tertiary center, but we forget about that first year. So when I actually started doing proper anesthetics in my CT 2 year, um, I was in a DGH, and now I absolutely loved it. And I was able to swangle staying there for a second year. So I loved it because I was given so much autonomy, and there wasn't that many trainees that wanted to go to that particular hospital. So I was the only core trainee there for my first year. And I think ethos inside a core in a DGH is it's more of a tight knit family, and you've got everyone's numbers. Now that I'm back at the tertiary centre, I don't have any numbers for any of the consultants. I just go through switch. But it's because there's just that many trainees and that many consultants. It's chaos. And they would, when I was at the other hospital, they would call me and be like, "Oh, Sarah, there's a central line in ITU. Do you want to come do it? Oh, Sarah, there's a midline in theatres. Do you want to come do it? Oh, Sarah, there's this in." They'd literally call me up and be like, "Come do all of these things," and it was amazing. And in your day to day, they literally leave you to it as much as possible, because that's the best way for you to learn, is to just be stuck in. And they're there. They won't leave you like totally. They're like looking through the window, but you are there intubating, ventilating, turning on the gas, transferring the patient, nerve blocks, etc., etc. You are doing it, and I got the best learning there. Now that I'm at the this tertiary center, I feel like I have maybe got de-skilled a little bit, maybe because some of the patients are a bit more complex, and the consultants, it's their neck on the line at the end of the day. They have like maybe a certain reputation that they want to uphold, and they're a bit more protective and like a bit more funny about me. They won't just let me just crack on with it. They'll hover over me a little bit more. So I personally prefer the DGH hospitals, but you'll have to go to both anyway.
Amazing. Thank you. So another question is, in terms of preparing your portfolio for
Mm.
ACCS anesthetics pathway as a medical student, do you have any particular advice?
So any electives that you've done, any awards or anything you've published, anything at all from your medical school counts, and it's really valuable. The key thing is, before you graduate, get certificates to like evidence what it is that you have done, because just saying it in your interview might not be enough, and you need to either contact if you've if you've done an elective in anesthetics, you should have a sign off sheet, or even pictures of you in that particular place, that counts as evidence. If you've been the head of a society, so it's a bit tricky, like if you're the head of a society, or you're even if you're a member of the society, it's easier if you remember to just ask the president to make you a certificate. But if you're the head of a society, contact the students union and get them to provide you with a certificate as evidence. They might give you a little bit of spiel, just tell them, for my medical career, I have to have physical evidence. So even photos of events that you've done, if you've run a marathon, or if you organize your like weekly football, take a photo of you there with your team, and that will show that you have like leadership, for example. Everything counts.
Yeah.
I didn't
And
have
I
any
think
awards or anything, sorry.
And no, I was going to say, and the thing is, this is information that we did not know as medical students. It's
Yeah,
really frustrating
hashtag regrets.
when you've graduated. Yeah, honestly, when you graduate medical school and then you're calling your university up and begging for pieces of
Yeah.
paper. So, as a medical student, the thing is, we're doing a session next week where I'm going to go really in depth about how to create a generic portfolio, because I'm sure you'll agree, Sarah,
Mm.
that all specialities require very similar things. So you kind
Yeah,
of just,
yeah,
as a student, you need to create one portfolio and
yeah,
then just season it
yeah,
based on the speciality.
literally.
It's a game plan, honestly. It's a game plan, but we'll go through that one next week.
Mm.
I'm just going to try to ask you a couple more quick questions.
Yeah.
One question is, when you were applying in your year, was it
Mm.
heavily dependent towards MSRA or more towards your portfolio percentage wise?
So in my year, we did not have the MSRA at all. I think they've
Okay,
just thrown this
fine.
MSRA as I don't know, to help filter things out a little bit. But it was very much portfolio. Like, you had to come in with this big lever arch of everything, and they would take it and like look through it before you were able to explain anything. And it was pretty intense. You had to like know exactly, you had 30 minutes to like go through any questions that they had. They would say, you know, tell us about an interesting reflection that you had in your F1, or, you know, while you were at work, and you had to flick through to your reflection that you've printed out from your e-portfolio, and be able to just like talk about it. And similarly, like I literally had like tabs, and I'd practice go through my portfolio, so it's very portfolio intensive. And I don't know
And
if that's going to be the case now, but just have a good portfolio
I think every
regardless.
year they'll love to change things, but you should always just
Yeah,
be prepared.
exactly.
Another question I have for you is, you know, for if you as emergency medicine with emergency medicine being run through, does that
Yeah.
mean that you don't have to reapply slash interview in the third year of core training?
So, yes, it means that you have applied to emergency medicine, you have applied to emergency medicine. Um, what it means, there's basically people can enter ACCS emergency medicine training at the third after the third year. Um, so you might start to see new faces, but once you have applied, you are an emergency medicine trainee in your deanery henceforth. Does that make
Mm,
sense?
okay, amazing. And then another question for you, Sarah. Are there any deaneries apart from the one that we've obviously working together that you'd have loved to have trained in for ACCS specifically?
Um, I kind of, well, actually, I don't know. These things are in Allah's hands. I would have liked to be closer to my family personally, but which is in Kent, and I've heard good things and bad things in that deanery. Um, it's really difficult to recommend a deanery. It is honestly purely down to your family, your personal circumstances, um, because everything has its pros. For example, the I think it's the KSS deanery. I'm not sure. I'm not 100% sure, but the that deanery is pretty large, and you a lot of deaneries, if it's pretty competitive, will do something like you have to do a year in London and a year out of London, or a place a placement in this place and a placement in that place, and the deaneries can be quite large. So if you don't want to be like commuting for an hour and a half, you know, think about that, and you can look at all of these deaneries and all of the hospitals that are in each
Mm,
deanery online. In the deanery that I'm at, even though it's like Warwickshire, they tend to keep certain, if you are like maybe East Warwickshire and you would prefer to be in East Warwickshire because you've got a house there, that's where you live, they tend to even keep you in that little like set of hospitals, because
mm,
it has, you know, the DGHs and the tertiary centres, for example. Whereas there's some trainees in your own deanery that you might not see because they are stuck in West Warwickshire and they want to stay in the sort of more towards Birmingham and those hospitals. So there is a lot of geographical things to take into consideration. Teaching does vary. That's the other thing. Mersey, um, I think that's northwest Liverpool
yeah, it's
area,
like Liverpool
is,
area.
yeah, is known to have like amongst the best anesthetic teaching, and they have like internet not they have national courses and stuff for exams there. And everyone just like seems to pass with ease, and it's like really, they're really hot on it. Maybe I should have gone there just so I could pass my goddamn Viva, but
Okay, we
it's
don't,
it's
please,
it's you know, shoulda, woulda,
exam
coulda.
trauma, exam trauma
Exam
is
trauma,
too real for
honestly, I'm
us
just
right now.
triggered.
Our hearts are broken at the moment. But anyway, we'll continue on.
For sure.
But Sarah, that is the final question I'm going to ask you because it's 5 minutes past 8. For
Okay.
everybody else, if you could please fill out the feedback. We will truly appreciate it. It helps us improve and it's fantastic for our speakers and their portfolios as well. In terms of a question I got asked regarding previous session recordings, I'm going to try and make things available at the end of the session. And for Dr. Sarah, Jazakallah khair. I mean, she's joining us from her maternity leave as well and giving us her time, which is incredible as always. But thank you very much.
Barakallah feek.
Then
Thank you,
I will
Saraya.
stay. I will stay online just for another 5 minutes, just so that people can fill out the feedback form. Sarah,
Okay.
and feel free to go. Thank you so
Wow.
much.
Peace out, guys. Thank you so much
Okay.
for listening. Assalamu alaikum.
Okay, guys, if you could just fill out the feedback form, we'll really appreciate it. Okay. See you soon, Sarah. I'll come and sit. Salam, salam.
Bye.
Alaikum. Radwan, you've asked, are we able to get a copy of the slides? Yes, I will speak with Sarah and I will get them for you, inshallah. And then we'll go. Just get in contact with me, please. Drop me an email. No worries. I'll stay on for a couple more minutes and then I also get to go home. Jazakallah khair. See you too. In terms of the previous sessions, I haven't made anything available yet. What I'm going to do is at the end, I'm going to try and